Welcome everybody again to another episode of the ideaXme show that profiles the humans behind the really big ideas that are shaping our world, inspiring future creators. And for all those really great stories, I'm Ira Pastor, your exponential health ambassador along for this journey today. Today we are going to move into the topic of spinal cord injury. And the spinal cord injury is sort of broadly defined as any damage to the spinal cord that causes either temporary or permanent changes to its function. Symptoms of spinal cord injury may include a loss of muscle function, sensation, autonomic function, parts of the body that are below the level of the injury. Injury can occur at any level of the spinal cord and be either complete, which is defined as a total loss of sensation or function, or incomplete, meaning that some nervous signals are still able to travel past the injured area. Depending on the location and the severity of the damage, symptoms can vary from numbness to paralysis to incontinence. Long-term outcomes vary widely from ultimately full recovery to permanent quadriplegia, paraplegia, and complications can include muscle atrophy, pressure sores, infections, breathing problems, a wide range of conditions. And currently, it's estimated that direct medical expenses of spinal cord injury in the United States can run into the millions of dollars, not including lost wages and earning potential, and include spinal surgeries, trauma care, rehabilitation, long-term care, medical equipment, and so forth. A recent estimate in the United States shows about 18,000 new spinal cord injury cases every year, and the total number of patients living with spinal cord injury in the U.S. about 290,000. So today's guest, who's going to take us further into this theme, as well as to some of the most exciting work going on in the development of innovative therapeutic interventions for spinal cord injury, is Dr. Wise Young. Dr. Young is both an MD and a Ph.D. He is Distinguished Professor of Cell Biology and Neuroscience, the founding director of the Keck Center for Collaborative Neuroscience, and the Richard H. Shindell Chair in Neuroscience at Rutgers University. Dr. Young achieved his doctorate in Physiology and Biophysics from the University of Iowa. He got a medical degree from Stanford, and for the last few decades has committed himself heavily to bringing innovative treatments to people with spinal cord injuries. He built and trained a 25-center clinical trial network in China, Taiwan, and Hong Kong, where phase 2 human clinical trials are going on right now in umbilical cord blood mononuclear cell and lithium therapy, and he's also establishing clinical trial networks in the US, Norway, and India. Dr. Young led the team that ultimately discovered and established high-dose methylprednisolone therapy as one of the first effective therapies for spinal cord injury. This 1990 work really upended many concepts that spinal cord injuries were permanent and really allowed research to refocus and open entire new directions of investigation and hope. Dr. Young also developed the first standardized rat spinal cord injury model used worldwide nowadays for testing therapies, formed the first consortium funded by the National Institutes of Health to test promising therapies, and helped establish several widely accepted clinical outcome measures of spinal cord injury research. Dr. Young also founded and serves as editor-in-chief of the Journal of Neurotrauma. He organized the International and National Neurotrauma Societies as forums for scientists to collaborate on spinal cord injury and brain research, and he served on advisory committees for the NIH, the National Academy of Sciences, the National Institute of Child Health and Human Development, and many other spinal cord injury advisory boards. His work has been featured broadly across numerous national and international news sources and print publications. He's appeared on 2020 with Barbara Walters and Christopher Reeve, on the Today Show with Katie Couric, 48 Hours, Fox News, CNN, USA Today, and in Time Magazine named him as America's best spinal cord injury researcher. Some of his many honors include being the first researcher elected to the Spinal Cord Injury Hall of Fame, the NIH Jacob Javits Neuroscience Award, the Cure Award. The list I could read for the next half hour. All this being said, Dr. Young, thank you really for taking the time to come on the show today and share your knowledge with us.
Thank you, Ira.
Much appreciated. So typically we'd start off the show by giving our guests the floor for a little bit just to talk about themselves. Obviously, in this area, there's not too many people that don't know about you, but for those that are new to the field and learning about it, can you just go a little bit into your background, sort of, where you grew up, how you got interested in science and physiology and medicine, and ultimately how you found a home at this sort of epicenter of neuroscience and trauma care.
I think you already covered most of my education. So I took care, in 1977, I was an intern at Bellevue Hospital when I took care of my first spinal cord injury patient. And It was very emotional for me because I think one of the things that all doctors hate is to feel helpless, to feel as if there's nothing you can do. And I had a 17-year-old wrestler, and I used to be a wrestler in high school, who broke his neck in a wrestling match. And I had to tell the parents that there was nothing we could do. Shortly after that, I had the opportunity to write several grants to NIH, and to my surprise, I got them grants. I think by the time I was 29 years old and I was just into my neurosurgery residency at that time, I had received over $1 million grant from NIH to set up a group to study spinal cord injury, and several grants to look at different areas of spinal cord injury, particularly in acute spinal cord injury. So I spent 20 years doing that, developing a therapy that we could use for acute spinal cord injury. 1997, I moved to Rutgers University, where I devoted myself to chronic spinal cord injury because there was nobody really addressing that issue of people who are already spinal injured. And this is I would say, I think honestly say that it's maybe one of the most hopeless groups of patients known. I mean, doctors would go into their hospital rooms on the day of injury and tell them they'll never walk again, even before they examined the patient. So it was really it's a field where you wouldn't even do that if somebody had cancer. You know, that they have no hope. This is really one of the most hopeless conditions in human history, that people have said that you will never walk again to many, many patients. And so I decided to take on a subject that I think most of my colleagues believed would be a waste of time. Even I think my mentor, my Ph.D. mentor, thought that I should go do something else more useful and interesting. So as it turns out, a lot of dogmas were, I think, broken in the last 10 years, not by me necessarily, but by more than 100 laboratories have now shown that animals can regenerate their spinal cord. And there's a lot of spontaneous regeneration going on in the spinal cord, and we don't pay attention to it, in part because a lot of this regeneration does not result in function. And it's very difficult to see nerve fibers, which are called axons, to connecting. And we, 3 years ago, in 2016, we published the first clinical trial showing that transplantation of these cells called umbilical cord blood mononuclear cells into the spinal cord of people with chronic complete spinal cord injury, which you just defined, people with no motor or sensory function below the injury site. These patients are chronic. They are, our definition of chronic is you must be more than 1 year after injury, and you must have no neurological change over a 6-month period. So that's a reasonable definition that you're complete. These are the patients who are told by all the doctors you'll never recover. And so we took these patients, we transplanted them with umbilical cord blood mononuclear cells, which have been matched for them. There are many umbilical cord blood banks all over the world, and we use something called human leukocyte antigen, HLA, matching to make sure that the cells would not be rejected. And we transplanted this into the patients. We published a study, 27 patients in 2016. We this is what is called an escalating dosing trial. We started out with a low dose. We gave double that dose and then double that dose to the patients. And we did a phase 1, phase 2 trial. The first phase is to show safety. We found that it was quite safe to transplant these cells. No patient lost any function. There was no deaths, no severe adverse events associated with transplants. Then and this was done in Hong Kong at the 2 flagship hospitals in Hong Kong. This is the Hong Kong University and the Chinese University of Hong Kong, really 2 of the best hospitals in the world. And we found that it was safe. We did a test that's called diffusion tensor imaging, which shows fibers in the spinal cord. We saw fibers grow across the injury site, and we were really quite excited, but none of the patients recovered any function, which was very disappointing. But then we went to the phase 2 trial, which was in Kunming. Kunming is the capital of Yunnan province, which is the southernmost province of China. There was an army hospital there that really did something very unusual. They're taking patients after spinal cord injury and walking them 6 hours a day, 6 days a week for 6 months. We call this the 666 program. And when they do this after injury, many of the patients recover function. I mean, as many as half of the patients recover walking. And that's, of course, because many patients are incomplete. And when you exercise them, they do walk. And we found that some patients with complete spinal cord injuries also recovered. But nobody had ever tried walking patients that were chronic complete patients. So in the trial that we carried out in Kunming, we did 20 patients. We randomized them to 5 treatment groups. The first 3 treatments were low dose, high dose, medium dose, high dose, and then high dose plus a steroid drug called methylprednisolone, which we found really makes the cells survive better. And the third is the high dose of mononuclear cells plus methylprednisolone plus a 6-week course of lithium, which we showed in animals improved the effects of these cell transplants. And the results are actually quite surprising. Well, first of all, without even looking at the different therapies, just overall, at the end of 1 year, we found that 75% of the patients are walking. 40% of the patients walked with what we call minimal assistance. Their quadriceps are weak, so their knees would buckle. So we had people walking behind them with ropes tied around the knees to sort of lock the knees as they are standing so their knees won't buckle and they wouldn't fall. They're standing in a rolling walker in which they're pushing the walker or somebody's pulling the walker and they're taking steps. They are walking like this 6 hours a day. And many of them actually, amazingly, you know, they look like in really good shape. I mean, if you walk 6 hours a day, 6 days,
Imagine.
you'd be really in good shape, right? Actually, we wanted to add an extra 6 to the 666 because many of these patients got 6-packs on their bellies because their core muscles actually improve a lot when they're walking 6 months. And you can see the muscles appear. But anyway, 75%, 15 out of the 20 patients we treated actually recovered walking, 35% of which actually walked without any assistance. And many of them stopped using their wheelchairs. And even more surprising was the fact that 65% of the patients no longer needed to catheterize themselves when they urinated. This was a bit of a shock to us because we didn't realize this. In fact, we didn't expect this to happen. So we didn't find out until we unblinded the study that this actually was happening. And what these patients found was that if they use 2 fingers, they tap themselves in the suprapubic region, you know, where the bladder is, and if the bladder is full, you know, they'll start peeing. And once the peeing starts, it just completes itself. When they catheterize themselves again, there's no more urine in there for them. And so 65% of our patients no longer use catheters to the bathroom. The other thing that's very impressive was that, you know, many patients with chronic complete spinal cord injury, they have severe constipation. I mean, this is something that happens. About 40–50% of the patients actually can't go to the bathroom without digital manipulation or putting suppositories in to stimulate the bowel movements. And so what happens is that many patients are really disturbed by the fact that their loved ones have to do that to them and have to help them do all these procedures. And I think many people would just tell me that this is the worst thing in their lives, that they become dependent on somebody else having to do the bathroom functions for them. So now we found out that nearly 60% of the patients have normal, regular bowel movements, and they don't need somebody to do digital manipulation or suppositories for them at all. And even more important, at this 1 month, at the 1 year period when we examined them, they told us that they have not had an accident in 3 months. In other words, they've become continent. Now, both the bowel and bladder function actually appeared late. We had the patients in a hospital for 6 months, and then we sent them home. And we didn't find out about this until we did our 1-year follow-up on the patients. So here it is. We have a therapy that restores walking in about 75% of the patients by 1 year. 65% of the patients are recovering bowel and bladder function. If you ask people with spinal cord injury, what do they want most in their lives? They'll tell you, we want to walk, we want to pee, we want to poop. And finally, if they're young, they want sex.
Mm-hmm.
And a bunch of them told us that they're getting better erections and better ejaculation. Wow.
Quality of life.
Now, this is obviously a small trial. And I have to say, you know, we published this in 2016. And I think there has not, probably you haven't even heard about this study. It was published in a relatively good journal, but we didn't go to the press. We didn't hold press conferences. What we did was we applied to the FDA to do the trial in the US. So they gave us permission last year to start the trial. And we're going to start the trial probably in the next month. The trial will involve hospitals in New York State, New Jersey, and Pennsylvania. We're going to be randomizing 27 patients to 3 treatment groups here in the US. One of the treatment groups will be no treatment at all. One of the groups will receive the cell transplants. One of the groups will receive cell transplants and lithium.
Okay.
We're omitting the methylprednisolone because we found out that the methylprednisolone didn't seem to help. We want to confirm that lithium is beneficial or not. So we have 3 treatment groups: a control group with no treatment, a group with cell transplant, and a group with cell transplant and lithium. This is done at you know, very good hospitals in the area: Mount Sinai in New York City, Hackensack Medical Center in New Jersey, the New Jersey Medical School, Kessler, and also we're doing this in a rehab center called Good Shepherd, and in Pennsylvania. So in Allentown. So anyway, these are very, very good centers. And actually the hardest part about organizing this trial was actually finding rehabilitation centers that are willing to walk our patients 6 hours a day, 6 days a week, 6 months. I mean,
Imagine.
People look at me and they say, "Are you crazy?" I mean, six. Hey, can we do 3-3-3? I said, "What do you mean 3-3-3? We'd like to walk them 3 hours a day, 3 days a week for 3 months." And you know, there's a very interesting that it's the rehab people that's giving us the pushback. The surgeons say, "Oh, no problem, we can transplant." It's a 3-hour skin-to-skin surgery, and the safety is very well established.
Sure.
Very extensive animal studies. It does not make tumors. By the way, umbilical cord blood cells have now been used to treat 30 or 40,000 people for many conditions, and it's never been shown to produce tumors. And these cells are essentially fetal cells. They're newborn baby cells that produce a lot of growth factors. And what we found was that lithium stimulates these cells to produce more growth factors. We transplant them into the spinal cord around the injury site and find that they migrate into the injury site, form a bridge. Then when we give lithium, or even without lithium, they're producing a lot of growth factors. And the nerve fibers follow them across the injury site and they grow all the way across. And what we found was that if you don't exercise the patients, and there were 8 patients in Hong Kong where we treated these patients, they get nothing back. They don't get bone bladder function back. They don't get walking back. Nothing. We just see fibers growing across the injury site. But if we treat them and then we have them walk 666, they get motor function back and bowel and bladder back. So after that study was finished in 2016, we went on ahead and did another trial that has not yet been published. And this trial was actually very surprising. This has been full of surprises for me anyway. We did 30 patients, we randomized them to surgery only with no cell transplants, just exposing the spinal cord.
Okay.
Then we had a group of patients that got no surgery, and we walked both groups 666. We were quite surprised to find that 1 year, 1 out of 4 patients in both groups recovered walking. but not great walking. It's worse than our treated patients. But to our surprise, patients in both groups recovered bowel and bladder function. So it's like the bowel and bladder recovery occurs even if you don't put cells into the patients. If you just walk them 6 hours a day, 6 days a week for 6 months, they actually will recover bowel and bladder function. And so what's going on here? Well, first of all, I want to point out, even though the patients can walk long distances, and many of, 35% are no longer using their wheelchairs at all, these patients cannot move their legs voluntarily.
Okay.
They're lying down, they're prone. We say, move your legs, and they cannot move their legs. Wiggle your toes, they can't move their toes. But once we put them on their feet, their vestibular reflexes, their anti-gravity reflexes, kick in, and they're able to take steps.
Sure.
And they can walk long distances, and they don't need to use their wheelchairs anymore. And even much better than that, none of the patients in our trial actually showed any decubiti, which are pressure sores, or urinary tract infections, because I think standing up 6 hours a day is very, very good for your bladder.
I can imagine.
So given this, we applied to the US FDA to do this trial in the US, because people would not accept just a trial in China. So the US FDA gave us permission, and we did extensive studies showing that it's safe, etc. But what is most interesting was that the US FDA forced us to do a control group, a no treatment control group. So I argued with them. I said, look, patients that don't get surgery, they know they didn't get any surgery.
Right.
So you can't blind that, right? And I said, those patients who don't get surgery won't work as hard as those patients that receive surgery, because they believe they received the therapy, they know. I was also afraid that none of the patients would want to be randomized to a third possibility of getting no therapy.
Sure.
We were quite surprised to find out when we talked to our spinal cord injury community that they don't mind that. As one of them said to me, here you're coming to me and you're saying you're going to put some cells into my spinal cord, and then 2 weeks later I'm going to go stand 6 hours a day, then I'm going to start walking, and I'm going to walk 6 hours a day. Are you nuts? I mean, I haven't walked and by the way, our patients in the study were from 2 to 20 years after spinal cord injury. These patients haven't walked in that long. They said, I'm not going to walk in 2 weeks time, start to walk and do all these things. You're crazy. In fact, they said, because we offered in all the control patients, if they don't receive the controls, at the end of 1 year, we'll give them the treatment.
Okay.
They said, wow, we would prefer to be in that group. They said, we want to be pre-trained and then get the cells and then get 6 months of walking again. They said to us, I'll bet you will walk better than those other guys. So there's a certain amount of competition involved, but there's no difficulty, no problems accepting being assigned to the control group as long as they will receive the therapy at 1 year. They think they'll do better. So this is the trial. We're going to do that. We're going to start that probably in beginning of December. And it's already been announced in the clinicaltrials.gov. And we've taken a lot of time. We didn't hold any news conferences, but I've talked to thousands of people with spinal injury. So they understand what this trial is about, why they're going to do it, why exercise is necessary, et cetera, et cetera. So by the end of next year, we'll know whether we can replicate the China experience. In the meantime, we're starting trials in India and Taiwan.
Okay.
And we're holding off on doing it in mainland China because that's where we originally did the trial, but we wanted to make sure we can do it in Taiwan. Taiwan, we're going to do a very special trial. We're going to go ahead and do what is called a surgical control. We're just going to operate on the patients without transplanting cells. Now, the reason why we did this other trial of 30 patients where we operated and didn't put any cells into them was to see whether there's any benefit or harm from doing that. And what we found was that, amazingly, those patients that got surgery, no cell transplants, recovered bowel and bladder function. So in Taiwan, the patients are very happy to be randomized to this, and they'll get the treatment at the end of 1 year.
I can imagine.
So we're going to do these 3 trials. The US one will probably start first in December. In January, February, we'll start Taiwan, India. And then, depending on the results of these trials, if we replicate our China experience, we will go ahead and do a phase 3 pivotal trial.
Mm-hmm.
And I'm, of course, hoping that the phase 3 will confirm the results of the phase 2, and then we will get worldwide regulatory approval.
Absolutely.
Right now, the whole field, everybody in the field is so pessimistic, they aren't willing to believe anything. You cannot convince them with a 20 patients trial or a 28 patient trial, which is what we had in China. They have to see it on a multi-center trial involving hundreds of patients. And so that we're going to give that to them. You know, to reverse human history, you have to do, you know, this is what I guess, just like the invasion of Kuwait or whatever, this is like overwhelming force. You have to do that, because once you open that door, what will happen is that many other people will say, I can do that too. The Me Too syndrome in pharmacology is very, very powerful. Everybody will want to do it.
Yeah, it must be, it must be extremely fulfilling for you to see it scale up finally in this context. And yeah, I know, having come out of the pharma industry for years, that, that they fight against you all the time and then they say, oh, it was self-evident that you would succeed. So, but yeah, I mean, it's truly amazing. I mean, is there just, as I don't have it as a side note, the whole situation with the controls, with the surgery and some improvement in terms of the bowel function and the bladder function. Are there any theories about why that is?
Yes,
something to do
sure.
with
All
morphodynamics?
these 3 functions are mediated by central pattern generators in the lumbosacral spinal cord. I mean, look, I don't know if you've ever tried to stop midstream when you're peeing.
Yeah,
it's hard.
Yeah, you can't sneeze either.
But once that program starts, it's hard to stop, and it just finishes. I mean, it's programmed into your spinal cord. Same thing with when you defecate, right? It's hard to stop it. Same thing with walking. Walking actually is a program that is located in your L1 spinal cord. By the way, that's one of the reasons why we limit the trial to C5 to T11. We don't want people who have lumbosacral damage, which might damage the central pattern generators, to be part of the trial. Although we will do them in a separate trial later on. At least at the present time, our current theory is that these centers are still intact, that there are fibers that have grown. They're non-specifically activating these centers in order to get these functions. And they can do that after extensive, intensive training. So that's the theory.
Very interesting.
And we found that actually, even without transplanting cells, that 60 to 80% of the patients are able to recover bowel and bladder function just from 666, walking 6 hours a day, 6 days a week for 6 months. Now, this requires a tremendous amount of commitment from our patients. I mean, if you're walking 6 hours a day, 6 days a week, you're not going to be working. You're just going to be devoting yourself to doing this.
Sure.
So what do I see as the future? I see it as this being an absolutely necessary step for recovery of function in a system that hasn't worked for years. You're going to take somebody with chronic spinal cord. I mean, if you've had a cast on your legs for, let's say, 3 months, I guarantee you'll find that all your muscles have atrophied.
Sure.
Same thing happens to the spinal cord. The spinal cord will undergo atrophy.
Sure.
And to rebuild that, you really have to put in the work and the time to retrain the whole system in order to work.
Absolutely.
And so our spinal cord injury community has accepted this, I think, very basic notion. But the doctors have not yet. There have been 3 clinical trials carried out in the last 4 years, which involved no exercise. And they stopped the trials. They shut down the therapies. I don't think it is because the cells don't necessarily work. I think it's because they didn't exercise the patients.
No, it's a fascinating finding, and it sounds kind of obvious just listening you talk about it, but you wonder why no one's picked that up. But it says something about you and the way you think about this. Going to the cells themselves. I mean, it seems that you've you're putting a lot of time into the neonatal blood mononuclear cells. But when I look at sort of your research, you've been very active in with other types of stem cells as well, neural stem cells, mesenchymal, and so forth. And also you've done work in the area of sort of these different inhibition factors to prevent teratoma formation, as far as the pluripotent or the embryonic stuff's concerned. Are the mononuclear cord blood cells sort of where you're primarily focused now, or are you also still looking at various different types of stem cells?
But we had to choose a cell that's practical, that's safe.
Sure.
So there are, umbilical cord blood has been now collected since 1989. There are about 100 some odd cord blood banks all around the world that have collected umbilical cord blood. They're using this to treat cancer, bone marrow problems, and thalassemia, sickle cell anemia, etc. And it has a very, very strong safety record. And now they're even using it to treat autism and other things. But the cells are available. That's number one. The cells are absolutely safe. And number three, it's affordable. It's not like, induced pluripotent stem cells, which may cost a ton of money because you have to make a custom cell for you. All you have to do is the same thing people do for umbilical cord blood cell transplants.
Gotcha.
The expensive part of this is really not the cells. The most expensive part is the walking training. But then what we're doing is we're trying to save a lot of money by introducing non-medical people to do the walking. You don't need a physical therapist to walk the patients. And we're using undergraduate students. I can tell you, athletes, we had a spinal cord injury at Rutgers, several years ago, and oh my God, every athlete wants to come and help. There's a group of people called kinesiologists. They want to do this, and many of our science students, they want to walk the patients. It's like the fulfillment of their science to see the results come out, and so we are actually very excited that we can do this. The veterans have come to me. They've said, can we come to New Jersey, get the cells, and then go back to our own VA to walk? There are like 57,000 vets with complete spinal cord injuries in the United States, being taken care of at the VA hospitals.
Okay.
So I said, sure, but we've got to get the walking program started in the VA. So I told them that I would. So I went down to the Atlanta, the VA hospital in Augusta, Georgia. It's the largest active duty spinal cord injury center. I'm very committed to walking. And you know what they said to me when I told them that in our trial, not a single patient got a urinary tract infection or a decubitus, a pressure sore.
Okay.
They said, do you know 80% of our admissions for our spinal cord injury patient base is for these two conditions, urinary tract infection or decubiti. They said, why are you talking about walking? You have a cure for decubiti and urinary tract infections. And they said each admission to us is over $200,000. So they're saying, look, why don't you come and walk the patients, have walking programs. So this helps with the decubiti and the urinary tract infections, and this will pay for itself. I said, wow, that's a great idea. So we're going to try to do that. And we're really hoping, one of the things that we know in the VA is that there's a very high suicide rate amongst vets.
Okay.
And as it turns out, many of the suicides are occurring in people with spinal cord injury. And everybody, they get their legs blown off or they get something, they're fixed, they go back. People who have spinal cord injury, they can't get fixed. And they don't go back to work. They don't go back to doing all the things that they can do. And so a lot of people just can't get back to work when they have spinal cord injury.
Sure.
If we have something that restores bowel and bladder and gets patients walking again, the suicide rate should go down. It was very interesting that the Michael Jackson's family, the Jackson Family Foundation, actually approached us to see if they could help do a VA system-wide program for walking people with spinal cord injury, and then doing this thing on a large scale. So we're actually very, very excited about doing this in the US, and then also doing this around the world. We're hoping to establish a new model. It should not be all medical. I think the 666 walking program should be done in part by non-medical people. You don't need to be a physical therapist in order to walk a patient. Yeah. You need to have some muscles and determination, right?
Absolutely.
And what is so interesting is that the people with spinal cord injury, they understand this innately, that they have to exercise in order to walk.
Sure.
And they understand it better than we do. So we're hoping to change the world with this, and we think that this is going to be true not only of spinal cord injury, but also stroke, multiple sclerosis, peripheral nerve diseases. All the neural disabilities will also require this kind of exercise. And we need to have a model where it doesn't cost $1 million to do this.
Sure.
And by the way, if we can argue with the VA that this is worth a $200,000 admission to the VA for UTI, urinary tract infections, and decubiti, this then will be, insurance companies will be very glad to cover this.
Sure.
Program. And so we want to start this not only in the United States, but in India, China, and Europe. And Norway, in particular, in Europe, has been very interested in this. They give cradle to grave medical care. It's the only country in the whole world that basically said to me, Wise, you come here, do the trial in Norway, we'll do it for free. Hospitals will cover all the costs. And because they immediately understood that if they can get the 4,560 patients in Norway walking again, peeing and pooping again on their own, they will save a ton of money.
I see that.
So part of this is not only the science involved.
Sure.
It's really the social structure involved to get these people out of their wheelchairs and walking again, to give them hope.
Absolutely.
And so that's been my work for the last 10, 15 years. It's been exciting.
It's an exciting set of work, and it's I followed you for years now. Rutgers graduate myself, and
wow.
Yeah, it's fascinating seeing. Obviously, everything goes slower than it should in this field, but you've definitely stayed with it, and it's just it's amazing where we are today in 2019. Moving a little back to you now, you mentioned early on that, I usually ask the question about sort of influencers in your life. And you mentioned that along the way, there were some people that said, Wise, you should get out of this stuff now. It's not worth your time. Anyone you specifically want to give a shout out to in terms of people that convinced you to stay with it? If it wasn't for them, you'd be doing, some cardiology or something totally different that you might want to mention along the way.
I trained with a scientist. His name is Rudolfo Linas. He was my Ph.D. mentor, and I'm very proud of the fact that he actually along the way changed his mind about things like plasticity and regeneration. I think the neuroscience field itself has come around to the concept of regeneration. They have come around to the concept that things will grow, things will change their connectivity so that they will restore function. I don't think the resistance is coming from the scientists. Also, I'm very grateful to the neurosurgeons with whom I worked for 20 years at NYU. There are too many to mention, but I can tell you one thing. Neurosurgeons they say, we can do this. It's only a 3-hour procedure. We can expose the spinal cord, we can inject the cells in. They're very excited about doing this. A lot of the pushback that we have right now is from people who actually deal with the day-to-day lives of the people. And for 30, 40 years, these people have been telling patients that they'll never walk again. And it's very difficult to change their minds, their mindset. And so and by the way, I absolutely do not want to bypass these people. I think these people are absolutely critical. That we need their buy-in with this intensive exercise program. If they don't buy in, then rehabilitation itself is in trouble.
Sure.
But rehabilitation really has to pay attention to the fact that you have to train people to regain function, and it must find more efficient ways of doing that. You know, technology will bring us a long ways, because you can stimulate a muscle 10 times a second, but you can only take one step every 2 seconds.
Sure.
So can you imagine the future? You'll be lying in bed, stimulating yourself, and you can do a lot of this stuff using technology, not just by walking 6 hours a day, maybe while you're sleeping, exercise and reconnecting things. I mean, there's a whole new world out there, and we need to actually start exploring this. And it's such a common sense thing that at the beginning, if you've lost all your connectivity and you're getting new fibers getting in there, you've got to teach your brain what buttons to push. If your brain doesn't know what buttons to push, you won't get any function. Actually, sensory function is really important. You have to know what the incoming signals are. Not going to be the same. So you have to learn new signals. It's like watching your baby walk. It takes them 6 months or longer to walk. So that's what we have to recreate in people who have not been walking for 20 years or longer. So it's really an exciting time.
Yeah.
And we need to bring the rehabilitation doctors away from the negativity. Basically the theory right now in rehabilitation is to teach patients to learn to live with what they have, to learn to live with disabilities. And so our goal is to teach them how to overcome their disabilities, how to regain function. This is a brand new idea in this field. And I'm hoping that they will buy in, and they're going to be the generation of rehabilitation doctors that will discover all these new ways of restoring function that we always considered to be impossible.
Sure.
And this is going to be true not only of spinal cord injury, but stroke, brain injury. Can you imagine that 90,000 people in coma, they have the same problem as somebody with spinal cord injury. They have parts of their brains that they haven't used. So anyway, these things should be so obvious. It doesn't require a rocket scientist or somebody like me to say this. But how come, I don't know if you know the story, that is really the saddest thing, I think, for humankind. When somebody has had a cardiac arrest or severe brain injury, they go into a coma. They're now, maybe from pressure from the insurance companies and so on, they're pushing to unplug them after 4 months, after 4 weeks. They've changed the term persistent vegetative state to permanent vegetative state, so that you give reason to unplug them, even though they might awake 3 months, 6 months, a year later. That's because of the cost. Also, it's because when they wake up, they're disabled. Of course, if you've been comatose for 6 months, you're not going to be able to function very well with your brain. And so this whole thing is going to extend because we need solutions for these problems. By the way, these problems will bankrupt our medical care system. We need to solve them. I think the answer is not going to be to kill them.
No. that's never the answer. And yeah, I'm in complete agreement with you on all these topics. And I think, one of the things also just, having hung around sort of the drug industry as long as I did, I mean, we've convinced everybody out there that the answers are just going to be the little white pill that we get at the local pharmacy, and that's it. And we don't have to put any effort into it. And as you're showing, like any system, the spinal cord is, it's its own little ecosystem of things. It's biochemical, it's biophysical, it's biomechanics, and you can't just think one little component of that system, a la systems biology, is going to be the single magic bullet that they like to, they like to give you in the pharma industry. And I think what you're doing is extremely important in sort of getting that message out there that you want to walk again. Yes, there's cells, there's some lithium, there's some other supportive compounds, but you got to get up and and move and learn to walk again as well. So I think that's extremely important, and just listening to your passion behind this, it's just it's very inspiring.
So let me just take another 2 minutes of your time and
no, take as long as you want. It's fascinating.
I'll tell you of one other problem I've been now working on for the last 5 years. As soon as we got the results of this trial, I knew that everybody with spinal cord injury will want this therapy.
Mm-hmm.
And umbilical cord blood cells, although there are lots of umbilical cord blood banks, I think the total number of umbilical cord blood units, each unit comes from one baby, is about 900,000 in the world. I estimate that there are about 3 million people with chronic complete spinal cord injury.
Okay.
Or chronic incomplete, even incomplete, but severe disabilities due to spinal cord injury, about 3 million people. That if, let's say, 10% of these people want this therapy every year, that's 300,000 people. In 3 years, the total world supply of umbilical cord blood will be depleted.
Mm.
It's like when there's nothing you can do, it's okay to sympathize and say, I'm sorry, there's no cells and there's no treatment. But when you do have a therapy that will restore function, boy, you better be able to deliver or people will get really, really upset. The other thing that will happen is that when you put a squeeze on a resource, the prices go up. It becomes unaffordable, so it becomes a therapy only for the rich.
Mm-hmm.
So I've now, with a very good friend who used to work at J&J, his name is Ken Jason, he and I have partnered up, and we're trying now to scale up the use of umbilical cord blood so that we can treat millions of people. And wow, that's been an exciting effort. So, for example, we currently only collect 5% of all the cord blood in the world. 95% of the cord blood in the world is just thrown away.
Mm.
One of the things is actually to collect a lot more cord blood.
Sure.
Number two is every unit of cord blood contains 200 million mononuclear cells.
Okay.
And we're using only 6.4 million to treat one patient. So each unit can actually be used to treat 20 patients.
Absolutely.
So just those two factors alone means that we can probably increase the number of cord blood cells available for treatment for very little money. You can do the math yourself.
Yeah.
If we, let's say, increase the collection rate to 20%, which is not that crazy.
No.
And finally, if we collect all the cord blood and split it into aliquot so it can treat 20 patients, that alone will give you millions of units to millions of doses that you can treat people with spinal cord injury. Now, there have been all these reports, more than 100 papers now have come out showing that umbilical cord blood cells are beneficial for stroke.
Mm-hmm.
It may be beneficial for macular degeneration of the eyes. There's 200 million people around the world. And it may be useful for treating patients with renal disease, like people who are on dialysis today.
Mm-hmm.
When you talk about these conditions, hundreds of millions of people, you need that many cells to treat them. Currently, no stem cell source can treat millions.
Right.
People are still thinking about treating 10 or 20,000. They're still thinking about charging $300,000 for this therapy.
Mm-hmm.
So what we're now trying to do is, and I've set up a company to do this, to provide a model where we can increase the collection rate and we reduce the price by 100-fold to make it affordable and to be affordable to third world countries. And by the way, it makes sense because third world countries have more babies than we do.
Sure.
India has 90,000 babies per day.
It's a lot of cord blood.
Yeah. And so part of this is solving the problem not just from a medical standpoint, we have to solve it from a social standpoint. from a
Absolutely.
societal standpoint to make this an affordable therapy so that the exercise plus the cells together maybe would cost, I don't know, $10,000, $20,000. You do that, then it would benefit everybody in the world. Anyway, so I've been working very hard on that part of it now, besides the clinical trials. That part I think is actually the most interesting and the most challenging. This is because there's technology involved. There's really a lot of economics involved, and just figuring out the solutions and getting the governments to and we have to have private-public partnerships and so on forth just to get these things going.
Sure.
And of course, I'm not going to be able to do all this. What is going to happen? I'm hoping to set things into place and have students and other people take it and run with it to get the infrastructure set up. And then it has to be run by people, really smart people, to make it so that it would benefit the maximum number of people. So this is what is really, really exciting to me. And we have a lot of very, very excited Rutgers students here.
I can imagine.
I've got whole bunches of students working in the lab. Not only that, volunteering to walk to patients, to figure out new ways of growing the cells, new ways of scaling the system so that we can get, right now it costs about $10,000 for one dose of the umbilical cord blood cells. I'd like to get it down to 100.
That would change everything.
And so these are the kinds of things that we're very excited about at Rutgers. We've got a whole bunch of really, really smart students who want to do nonprofit medicine. And boy, it's a really exciting time to be in education.
Absolutely. I can imagine, and I'm just glad to see it happening at Rutgers, and right nearby. Dr. Young, it's been very inspiring, just hearing you talk about all of this, and once again your passion behind it, the fact you've stayed with it, which is a rare thing nowadays in this space, and I just really wishing you the best moving forward. And once again, for everybody that's watching on the YouTube channel, but also will be listening on the various radio networks, we've been spending time with the amazing Dr. Wise Young, Distinguished Professor of Cell Biology and Neuroscience, Founding Director of the Keck Center for Collaborative Neuroscience, and the Richard Shindell Chair of Neuroscience, all at Rutgers University here in the Northeast United States. Dr. Young, really, thank you so much for everything you do. Thank you for the time that you put into this, and really, as we say, moving the human story forward, not just here in the U.S., but everywhere.
Thank you.